Hey there, welcome to the Pelvis Project podcast. I'm Megan.
And I'm Roxy. We're two pelvic health experts brought together by passion for our careers, entrepreneurship, motherhood, and the desire for intentional relationships.
Join us in our mission to spread pelvic floor awareness and start conversations surrounding the truth behind genuine health, imperfect wellness, and joyfully navigating life. We are so glad you are here with us.
Let's start the conversation. Hey, hey, hey.
Hello, we're back for another Pelvis Project After Dark. 9:20.
We're gonna jump in and get this show rolling. Tell me something good, Megan.
Ooh, okay, let's see. We'll do a firing lightning round. Let's see. This was my first weekend in quite a while that I didn't have to show up to some sort of work thing where I needed to be present. And I also chose to, not really do any work related things at home, except for today. I did have to do stuff today only for about an hour. And so anyway, first weekend of that, and the first weekend of fall baseball for my son. And it's just such a fun time getting to watch him. And we're just kind of keeping it fun right now and nothing too serious. So it was a great weekend to get to do that, even though it was cold and rainy. And, first few days of fall here definitely showed up and sat and watched baseball in the rain. But it was really good and just nice to kind of feel, it's a little bit like the good old days on the weekends. What about you, Roxy?
Oh, it's just been a mix of goods and not so greats. But I think just today, I really like rainy days. They really refresh me. Rainy, cloudy days just feel clean. I don't know. There's something about it that I really, really like. I think that I just needed that little bit of a cozy day or something, we didn't do anything super special, but I did. Okay. This has kind of been funny. I introduced Isla to Princess Diaries and she is a huge fan.
Oh, I love that so much.
So we watched Princess Diaries 2 today, this afternoon while it was raining, and she just loved it. She thought that was great. Her favorite quote from Princess Diaries is when Mia walks through the grass at her grandma's whatever place, and over the intercom they say, "Get off the grass."
Oh, that's so cute. I love it.
That's hilarious. So anyway, I feel like that was fun to just be let's watch this little.
I love it. We watched Grace. We have tried to watch Gilmore Girls together multiple times, and just never really got it going. And so we've been trying to do that. And so I told her today, I said, "Hey, come up here. Let's watch an episode." And I mean, she turned it on in 5 minutes. I was asleep. So I took a little siesta. I told her, I said, "I've been listening." That's what I told her.
Just resting my eyes.
Just resting my eyes. Yep. So anyway,
it's good.
It was a good rainy day.
Yeah. I needed it. It was great.
Yeah. Cool. So we're going an episode we haven't covered or talked about is, and we might have alluded to it in other episodes, but talking about what we treat as far as what's referred to as dyspareunia or vaginismus. So they're two different things, but basically in a nutshell, painful intercourse, and we'll break that down into the two differences. But basically when you have pain with any sort of insertion of tampon, pelvic exam, anything like that. So we're going to talk about the two differences between vaginismus, dyspareunia, and kind of how we go about that, what it is, how we treat it, what we see, because this is something that has come up, I think, both for Roxy and I recently, of just different stories that we have people coming into our clinic and wanting to get more women to know that it can be treated and that it's not just quote unquote normal. So yeah. Roxy, why don't you start us off with, let's cover vaginismus, and then I'll go into dyspareunia.
Okay. A lot of times too, just as we get into these, people will interchange these, and there's actually a pretty big discrepancy. So vaginismus then What it is it's an involuntary contraction of the pelvic floor muscles with really any kind of stimuli. A lot of times that's associated with penetration, though. So, like, if it's pain with a tampon, pain with a pelvic exam, pain with intercourse, like all those fall under vaginismus. But what we also see is like if we're palpating externally around that area, like that, and the muscles will seize up and as a response to just the stimuli in that
Yeah.
area. And so that's like that's kind of a bigger difference of like just vaginismus as an overall pain with anything in that area.
Yeah. And I think we can both agree. We have people come in with these diagnoses all the time. And for us, we don't really need to put a name or a diagnosis to it because we're going to treat it the way, we're going to treat what's in front of us. We're going to treat the person, not the diagnosis, is something that we like to say. It's just very interesting because these individuals, if you're somebody that is resonating with that, it might be that like you've tried tampons when you were younger and you never really could tolerate them much. And you just, didn't use them. And then later down the road, when, you decided to get intimate with your partner and, intercourse was extremely painful, couldn't even really complete like any insertion. And often then that just gets put into painful intercourse, but it's beyond that. So I definitely think it's good to know the difference between the two. And then dyspareunia is what we refer to. It's the medical term for painful intercourse. And then there is superficial dyspareunia or deep dyspareunia. So that could mean that you have pain with the initial entry with penetration, or you have pain with that more deep penetration. And so you can have a combination of the two, or you can have one or the other. And again, we're going to be looking at, we'll talk more about this, the contributing factors to it, but we're going to be looking at, okay, what factors are playing into this? Because for both of them, there's definitely different layers to the progression of helping somebody work through these. But yeah, those are kind of breaking down the difference between vaginismus and dyspareunia. And I will say a story about this. I was filling out some intake information with my OBGYN's office, which I've been going to since I was a teen. And of course, they have you update everything every year. And it is very fascinating now for me to fill out that information as a pelvic floor provider. And it asks on the intake or on that form, do you have dyspareunia? And it doesn't ask, do you have pain with sex or pain with intercourse or pain with penetration? It just says dyspareunia. And I thought to myself, wow, like most people don't know what that word even means. So they're often going to put no because it sounds like some word of like, well, I don't have that. And so they're going to say no. And then often when we go see our doctors, no fault to theirs, they're just asking us questions from what we marked yes to. And so it can get missed and overlooked. And then depending upon your personality, you might be nervous to bring this up to your doctor. And then it goes undiagnosed or untreated. So right there, first, recommendation would be if you're listening to this or somebody that's had a problem with, pain with intimacy or pain with insertion or penetration, go ahead and bring it up to your provider because they need to know about it. Okay, so next we're going to talk about just like common causes and contributing factors to vaginismus and dyspareunia. So with vaginismus, we definitely have some psychological factors to that can play in. And by no means let's be clear here. We hate it if someone is told like it's all in your head because it most definitely is not all in your head. But with vaginismus and dyspareunia, both, it can cause and can be increased by having increased anxiety, trauma, sexual abuse, those sorts of things. And I tell people with vaginismus because these are the individuals coming in that say like we tried and it just feels like we're hitting a brick wall, and I just can't hardly even like I can hardly even stand this. It hurts so bad. And I like to, share that those muscles, particularly our superficial muscles of the pelvic floor, part of their job in connection with the autonomic nervous system is to protect. And so if there is a factor that the nervous system interprets as
A danger.
a
Yeah.
danger, sorry,
Or a threat.
a threat was the word that I want to, even though you may be very open and want to do this, if the nervous system interprets it as a threat, then those muscles are actually doing what they're supposed to and they're trying to protect you. And so that's that first piece of like, okay, like trying to get to that layer of we need to start understanding our body and that mind body connection. And then also with this, we address to make sure that we do have mental health therapists on board for this if we need to. And then also for vaginismus, we got those physical contributors too. So pelvic floor hypertonicity, which is the pelvic floor tightness. So those muscles are just really tight. And we're not talking like, maybe it's like everybody says, well, for your first time, it might not feel that great. Like this is beyond that. This is those muscles are very painful with mobility also. There can be hormonal changes, infections, different things that we need to be paying attention to that could be leading to some of this, like recurrent bacterial vaginosis, stuff like that. But we definitely are taking into consideration all these different components that can lead to what we look at as vaginismus. And those are just some of the common causes. Obviously, there's a lot more, but we're just trying to kind of keep this a little bit streamlined. So, Roxy, why don't you tell us common causes and contributing factors with dyspareunia or painful intercourse?
Yeah. So obviously, Megan touched on like the psychological factors or just the trauma, but a lot of times that is related to a little more of like a condition or a mechanism of injury. Not always, but we typically see that there's a reason. We can trace it back to like a specific reason. Maybe there's already pelvic pain. So, like diagnoses like endometriosis or adenomyosis or pelvic inflammatory disease or like scar tissue following a vaginal delivery or things like there's like an event kind of not always, but just it just seems to be like there is usually some type of a physiological reason that we can kind of nail down of like, okay, it didn't hurt and then now it does,
or it's slowly gotten worse.
yes, it's progressed or it's symptom of something bigger going on that thing is fueling it. So like already having a diagnosis of some sort or some sort of mechanism of injury there. And so the pelvic floor muscles then are also then that's where it gets a little muddy because then the pelvic floor muscles are guarding like our body was made to do, which is I think a really beautiful thing that we have. But when we don't want it to be doing that, or when we know we're in a safe space or whatever, then that can be really frustrating. But the pelvic floor muscles then aren't coordinating correctly. They're not relaxing when we want them to relax, and they're not engaging when we want them to relax, or when we want them to engage, pardon me. And then there's that hypertonicity where they can be tense then. Anyway, it can get to be a little muddy because there's always a nervous system component to it because when we have chronic pain, then our body is more on guard and it is like ready to protect us more quickly, or it's going to be on the defense a little bit quicker and sooner. Anyway, that's kind of just the big difference that we do see is usually that dyspareunia. Sometimes it wasn't painful and then it at one point it wasn't painful. And then, usually then after so long or after something happens, it's progressively worsening is like a pretty common trend or journey that we see with these folks.
Yeah. And I always like to let people know that it only takes one time for you to have painful intercourse. And then you're like, oh, well, what was that about? And so there's an anticipation of the next time. And so we really do have to, there's just, like Roxy said, such a nervous system component to this that, again, what she said, it's a beautiful thing that the body is trying to just give you like a bit of a heads up, like, hey, remember last time, maybe we need to do something different. And so we're just there to help guide through. And honestly, working with patients that deal with either one of these is honestly just such an honor to help somebody through these symptoms and diagnoses because the outcomes are generally very positive and women just make such big improvements. And also for those women that maybe have gone through menopause, that weren't necessarily followed with maybe hormonal assistance and that sort of thing that start to have painful intercourse. And so they just stop because they think that it's just like done. And being able to bring that back and be like, no, there's actually stuff we can do here, and helping guide them on the right providers, and or just helping with conversations with their current providers, giving some suggestions for tissue support, and maybe a little bit of, dilator use again, depending on how long it's been, for or vaginal trainers, if you want to refer to them as that. And yeah, to be able to be intimate again with their spouse or partner. And it's exciting. So we'll talk more about some of the things that we hate women, that like we hate about what women are being told about this, but that is just kind of those contributing factors. So we'll talk next about the role of the pelvic floor physical therapist. So like, what's our role in it? So basically, we're going to do an assessment, and we are going to evaluate the patient, and we're going to take a very in-depth subjective history, so that, like Roxy said, we can find out, you know, we see from very early on, like, did this start when we were a teen? Like, when did we notice all of this happening? And so we take that really good history and we really take time. I know both of our clinics, really the way that we're designed is so that we have the time to sit with you and let you unpack it, because this can be fairly emotional for women. The amount of shame that is carried into this when someone, has not been sexually active before their wedding or getting married, and they are excited, and then they go and try to be intimate with their partner, and suddenly they realize they have all this pain, and there's all this fear around, like, am I not going to be able to do this? And just a lot of heavy feelings. And so to be able to sit and take a very good, not rushed history, and then the physical exam, which it's always an option. You are never forced into doing any sort of internal assessment if you do not want to. We have plenty of tools in the toolbox to be able to do an assessment externally. And often with these scenarios, especially if there's trauma involved, different things like that, it's good to separate them out into 2 sessions, just so that everybody's, so that you're comfortable with your physical therapist, and we don't have to rush, because a rushed nervous system is a heightened nervous system. And so we want to be able to move slowly with that. And then, yes, the importance of creating a safe and supportive environment is the primary, most important thing, because if you do not feel safe, then it is not the most therapeutic option for you. There's a lot that goes into how we both have chosen to set up our clinics, and the lighting and the feel and the way things look and the way the temperature, all the things to try to help support the nervous system. We call them neurotags. And so through that assessment, again, it is an honor to be able to do. So that's how our first role is to be able to assess everything. And then Roxy, take us into kind of treatment approaches.
Sure. Well, one thing too, we had a really in-depth conversation about, just if you're or haven't listened to very many of our episodes, if you go back to 15, we really dive in on the internal assessment there. So like if that's feeling like really uncomfortable for you, you're unsure what that looks like. We don't really mean to breeze over this, but if you want to go back and really listen to like what that would be, that'd be a good one to check out if you have more questions. But yeah, so then for treatment, like this is going to look very different for each individual that's in front of us, how they present. So in no way am I presenting a cookie cutter picture of what we do, but just some things that we can do is obviously manual therapy techniques. And that can be a lot of different things. That can be that can be hands-on treatment internally right at the pelvic floor there, if that's appropriate for that person. Can also be, we work on the spine, we work on the hips, we work on the fascial connections, we work on the abdomen, the inner thighs, like however the person presents, that we see, if we can get our hands on that person and help guide their body and help bring awareness to different areas and help their body overcome just that chronic tension and guarding. And I feel pretty confident just to say that because that's how these people present, is there's tension. We talked about that in the pelvic floor. The pelvic floor is really tight and it's guarding. And you think about if you're bracing for impact or you're nervous or you're afraid, you think about how your whole body just tenses up. So we're looking for the different parts of the body that are doing that chronically that people are unaware of. And they don't even realize, their body doesn't even realize it's so tight. So we use our hands and tools and different techniques on the body. And that's a really big piece, but that's not the only piece. We also just are going to do a lot of education with that, whether it's just anatomy education or understanding the pelvic floor and pain and the nervous system and why our body responds the way that it does. And then as we do that, then we help, if we're going to say, well, this is what your nervous system is doing and your nervous system is guarding you and it's protecting you. And that's really great when you need it. But right now you don't need it. Then we're going to give strategies of how to help relax the nervous system. And that might be different breathing exercises, some vagal nerve type stimulation, just helping the pelvic floor relax too. That is a whole big topic of just helping the body to not be tense. Like obviously that's the number one goal. So we go about that about 15 different ways. But that's just like a big umbrella statement of relaxation techniques. Sometimes what else can be helpful is like dilator use of just like a almost like a graded. So taking a really small dilator vaginal trainer and having your body get used to that, kind of desensitize it to an object being right there. And then you kind of slowly increase as tolerated and you're just desensitizing. It's kind of like a low load, long duration type stretch, if that makes sense, but for the pelvic floor muscles. And then, just a lot of like talking, like helping make sense, connecting dots, that like the cognitive side of that and some behavioral strategies of helping you identify how your body is responding in certain situations. And so how to react then when your body has reacted, and how do we then help our body come out of whatever it's kind of automatically done. And then what can be really powerful is once you really see how your body is functioning and how it's automatically responding to different circumstances, then is really working upstream and trying to prevent it from doing that too. And so kind of working on both the responsive, trying to respond in a healthier way, but then also prevent like a bad response that you then would have to undo.
Yeah.
Megan, do you have anything else on any of that? That was kind of a big,
no, I think,
dump.
well, I mean, like just for example, I really like with patients that come in, especially more with kind of the vaginismus where like maybe penetration is not even has happened yet. But it's kind of like, okay, you come in and we have that initial evaluation. We may or may not do an internal assessment that first day. If someone wants that done, we can do that then, or the second day, whatnot. And that point is when we can really start laying down the foundational pieces of what we're going to anchor ourselves to, which is like the breath exercises, teaching how to release the pelvic floor, that sort of thing. And we're going to keep circling back. And those foundational pieces have to be there to anchor us down. So to be able to get those there. So I tell people, give me 1 or 2 visits of that. Then the next couple of visits, you're going to get used to me. Like you're going to get used to, my hands working on fascial release or it just internal gentle stretching or adductor work or that sort of thing. You're getting used to somebody working on you basically, and because if you're not used to that, it takes a little bit. And you start to get confidence and realizing, okay, this is a safe environment. I'm now actually ready. I can tolerate, oh my gosh, wow. Like today, that initial internal work we did, actually, my body did really great with that. It gets you some confidence and empowerment. So I tell people, I'm like, and this isn't, again, no cookie cutter way, but I see on, typical, it's like, give me those 6 visits where maybe I'm seeing you more once a week and then get you started on maybe those for depending on what the main issue is. If we're doing vaginal trainers or whatnot, get you started on those. People start to get some really amazing groundwork with those and you can tell their confidence improves. You can start spreading out visits. So they have a couple of visits in between to keep working on that. And it's just amazing what can happen. And then they're back in your clinic and they're like, we were able to have intercourse and I just felt a stretch. It wasn't painful at all. Or we were able to do this and I felt a little bit of discomfort, but I remembered what you told me and I took a breath and I did this and it went away. And I'm just, gosh darn it, so proud because this is hard work, like if you're going through this, pat yourself on the back because it takes a lot that is something you don't want to have to think about. So treatment approaches are different for everybody, but man, it's like you see patterns and you can kind of guide which way, you need to adjust and have really great outcomes. The outcomes are really great. So Roxy kind of touched on this, but multidisciplinary care and collaboration, it's really important to us that we make sure that we have a team approach. And typically our patients are already been working with their gynecologist or OBGYN. And we love to be able to have a really great open relationship with them. If we see anything that we need to have them circle back on or get follow-ups for, or if we need any sort of medication, that sort of thing, like estrogen, or maybe we notice that someone's got like some lichen sclerosis, stuff like that. We really love to be able to have a great collaborative approach. Sex therapists are super important to us, and or therapists that focus on trauma or really anything. If somebody's seeing it and they have this issue and they have a therapist they've been seeing for a long time, it's really just somebody that that they're really comfortable with talking about this stuff to. And maybe I can't tell you how many times I've asked somebody like, do you have a therapist? And they say yes. And I said, have you talked to him about this? And they say no. I'm like, okay, let's have that conversation. And your therapist will tell you on if they have the capacity to be able to help you through this or if they think you need to see somebody else. And then, of course, I mean, there's pain specialists, things like that. But typically, we don't really have to go that route. Most of the time, it's, us and your OBGYN and or your doctor and sex therapist. So, and then we just, we talked about, obviously, we have the referrals for mental health professionals, psychological support, that sort of thing. And then just how, like, explaining and educating our patients, like how the disciplines work together to improve outcomes. And I would also say going into this with a collaboration of care is also making sure that our patients' spouses are, in the loop on this. Often I ask women, like, have you told your husband about this? Or have you told, have you had this conversation? And sometimes the answer is yes, and sometimes it's no. And so if it is a safe environment and it's a safe relationship, we always just encourage that so that women don't feel like they're alone in this and that they don't have to hide anything. Because if you are feeling like you have to hide something, that's going to impact that healing process. So I've even encouraged some of my patients, their husbands might come into a session just so I can explain to them what's going on. And it's just so lovely to see just partners come together and they actually grow closer together in this. So it's just something really beautiful. So, all right, Roxy, tell us some common myths and misconceptions with these two diagnoses.
Oh, where do we start?
I know.
There's just a lot, but some of the big ones are, and we see this with really any kind of like chronic pain or unexplained pain that people are dealing with, that maybe just the general person they're working with before they get to us isn't sure on, but just this idea that it's kind of all in your head or that it's your body is just guarding and that it's not actually, there's not something musculoskeletally or physically wrong with it. And
Yeah.
that can be really a defeating message to hear for these people. So, and I don't always think that that message is intentionally given that way, but I think that some well-meaning providers maybe try to explain the like pain processing side of it, and that gets interpreted or maybe isn't explained well.
Yeah.
And so that patients walk away thinking that it's all in their head. And so
Right.
I think just understanding that even though pain science is like that approach is a very mental, heavy thought process, and it's not wrong. It's just one piece of a bigger puzzle. And so if you've ever been
Right.
told in any kind of pain from a provider that it's like essentially if you walked away with the message that it's all in your head, hopefully that wasn't the message they were trying to give you, and they just had a struggle of explaining it. But
Yeah.
that's just a very, very common, I don't know, educational piece that's just been skewed, really.
Right. And I think with this, just knowing what we're trying to say is vaginismus and dyspareunia or and painful intercourse. It's not when we say it's not all in your head, we're saying it is not purely psychological. And that is what that's sometimes how it could be communicated. We're saying there is more to it than that. And so rest assured, that's why I tell people this is not in your head, all in your head. Like your muscles are physiologically, there is a muscular skeletal component in that same sentence. There also is a component that now, because that's there, we do have this part that is like, oh my gosh, now we have this like loop of pain. So it's just that it's multifaceted and there's layers to it, but never let somebody, I repeat, never let somebody tell you it's all in your head. Just go have a glass of wine and relax, because that is not going to make this better.
Yeah. And then kind of along with that is, I mean, just that whole like relax and have a glass of wine or whatever is just that pain during intercourse can be a normal thing. That's never the case. Like pain with anything is never normal. And so
Yeah.
sometimes that message, like drink some wine or just relax or, don't be so uptight. Don't be so uptight
Yeah.
about it type of a thing.
Yeah.
That communicates the message that this is normal and but you have to just chill out kind of thing. And
Yeah.
so anyway, but the bigger point that pain during intercourse is a normal thing is 100% false. Pain's never normal. And intercourse is meant to be a very beautiful and pain-free and enjoyable and intimate time. And so if pain's in there, then that's actually the opposite of it. And if we want to get really nerdy, I mean, pain is going to increase the sympathetic side, which is the fight or flight. That's your survival mode. If you're running for your life, your body isn't going to support intimacy. And
Yeah.
so it truly is. Pain and intercourse are on opposite ends of the spectrum. Intercourse falls under the parasympathetic side of our nervous system, which is all good things. So anyway,
Yeah.
without getting too much in the weeds of that, they literally are polar opposites. And so they are not meant, your body's not created to have those two be codependent at the same time. That's not function.
Yeah.
That's
Yeah.
dysfunction. And so pain with intercourse is never normal.
Yeah. Yeah.
Oh, and then some people I think that just accept then that it like as a deeper spiral from that idea of that pain is normal, that then like they can never recover. And that's very false too. And so it's never too late. Your body is very capable of healing and being better and functioning better. And so if you've been having this for years and years and years, I just had a gal I was working with. She's been having pain for 20 years, over 20 years.
Yeah.
And she had just had so many people tell her some of these things. And she's having sex without any pain right now, and I don't know if right now that'd be funny. But anyway, like currently in this season of life, she's overcome that. And so that just, I know Meg and I both could probably just tell you story after story of people who have had chronic pain and just accepted it as their new normal, thinking that it's been going on so long, there's no way it would ever go away. And that's not true either.
Yeah. I know. I think that, we see such a wide range of like young women and also women who are 65 plus that, yeah, they realize after maybe they stumbled across something like, oh, maybe there's something I could do about this. And there is. It's never too late. And there's so much that, gosh, as you were talking, Roxy, my mind was just going all sorts of different places for like the different scenarios that we see and helping women through this and what they've been told or believe. And yeah, I think that if you're listening to this and you're like, oh my gosh, this sounds like me, and I just thought it was normal, find yourself a pelvic floor therapist. If you're in our area, call us. Because, I think sometimes too, just a couple of visits to shed some light on what's going on and how to outline a path to, improving these things can be, I mean, this is where people say this is life changing. And I also, this goes into, like, for example, if you had a hysterectomy, okay, let's just put this scenario that we see happen. Let's say you have endometriosis. And so you've had this chronic pelvic pain for a while, and maybe you had pain with sex and maybe not. Maybe it was kind of like, intermittent. And so you never really addressed it. And maybe, we're just now starting to try to get doctors to refer to pelvic floor therapy with an endo diagnosis, because maybe we need to do a whole episode on that of why it's important. But okay, so let's say you've had this chronic pain that is cyclical, that comes every single month, that is really, really bad. And that happens year after year. And that pelvic floor goes through having, to spasm and tighten and carry around that tension. And so eventually it becomes where there's some dysfunction. And you go and you have a hysterectomy, and they're like, okay, we're going to do this hysterectomy and all your pain's going to be gone. And so you have your uterus removed, potentially your ovaries, maybe, maybe not. And now all of a sudden you have painful intercourse. You're like, well, I didn't have this before. And a lot of times women just feel like, oh, well, this is a product of my decision to have a hysterectomy. No, you should be able to return to sex post hysterectomy, obviously after your recovery period and everything. But what can happen is, when you have a surgery in an area, it's kind of like, again, we always use like the knee surgery equivalent of this. But if you had knee surgery and 6 weeks went by and then suddenly they were just like, yeah, you can go do whatever you want. And someone started moving around the tissue around where the surgery was, and it would be a sore. And so we still have to consider you had a major organ removed, and those muscles have now been in a pain pattern and a pattern of protection for a long period of time. And so I guess my point in telling you this is we see so many different reasons for why somebody might come in with painful sex. And I think it's just, don't ever think, well, this is probably just because XYZ. It shouldn't happen at all. And you should speak up to your doctor so that they can get you to the right pelvic floor therapist. And if they say like, oh yeah, that's just normal, go find somebody else to talk to. Um, and also depending on what state you're in, I mean, for us in Kansas, we are a direct access state. So you don't need a referral. And if you know this information and your doctor doesn't give you one, you can still come see us. So just totally went off on a little soapbox there, getting fired up if you can't tell. Okay, so let's give some practical advice here to our listeners, Roxy. So my first piece of practical advice is just giving you some tips to recognize signs of pelvic floor dysfunction early on. So if you're noticing pain with tampons, if you're noticing pain with pelvic exams when you go for your pap smear, if you're noticing pain with, penetration or with sex, anything like that, the sooner you notice something like that, like recognize it early and go see a pelvic floor specialist. It might even be things like you leak when you sneeze and you are young and you're like, oh my gosh, I can't believe that just happened. Like those little signs of things. Are you constipated? Do you leak when you sneeze? Are you having pain with tampons? Do you just generally feel like you have this like tension about you? Did you choose to, maybe you got an IUD placed and it was awful when you had it placed from pain? Those are those little signs and things that just start thinking about like, I wonder what's going on with those muscles and I want to get them checked. So, Roxy, what's another practical piece of advice?
I think just taking care of yourself. And this goes beyond, that was a really broad recommendation. But this just goes beyond. So Megan's saying, really notice what's going on in your pelvic floor and be proactive if something's, not happening correctly there. Now I'm going to contrast that a little bit and say, let's go outside of that and just think about our whole body. and look at the rhythms, just the self-care patterns that we have. Are we hydrating? Are we fueling our body? Are we resting well? Are we moving well? What are our rhythms? Are we really stressed to the max all the time? Or are we giving ourselves time to come back and restore and be restored and rest and all those things? But those really feed into that nervous system piece, like we were talking about earlier. But it also helps the body recover. Sometimes stress can be really good, and we want to be motivated. We want to be productive, and we want to just be living healthy. But then we also need to contrast that with the downside of that, not down in a bad way, but the lower level of just not being so tense and high strung and maxed out all the time.
Yeah, definitely. For sure. And I think just like encouragement of seeking professional help if you're dealing with any of these. And also like making sure you just have communication with your partner about these things. Like those are and obviously this is just podcast advice. We would tell you to obviously go see your healthcare provider. And another little nugget, please don't do any of the like just quick fix sort of things or think like, oh, if I buy this device and I insert it and it's going to do something that's going to you know, help my pelvic floor. And it ends up, it's something that's like muscle contractions. And there's just a lot of stuff coming out where it definitely feels like people could be very much taken advantage of. And anything that is going to try to sell that it's a quick fix, we don't really love, because what you miss there is the piece of really connecting with your body and learning how it functions in a very intimate spot that a lot of us as females are never taught about really in school. I mean, I have had individuals come in and I'm going through and showing them anatomy and they didn't even realize that there's muscles down there. I mean, I didn't until I went into college of a medical. I mean, it makes sense, right? Like how you don't even think about it though, because a pelvic floor that functions correctly, without dysfunction, you don't even think about, well, how does my pee stop and how does my pee, is it released and those sorts of things. But if you're skipping over that piece of that connection with your body, again, we're teaching ourselves to override. And that's why, again, we've said this before in other episodes, don't love the devices that are insert and you will have less leaking and you will have better sex and you will this and you will that. Like that's a band-aid. And the women who take the time to really kind of learn about what's going on, that's where the major deep success comes in. So that's our little advice there. But otherwise, gosh, we covered a lot today as far as knowing like what dyspareunia and vaginismus are, kind of how the factors that go into these symptoms and diagnoses and all the things that we consider when we're treating it. So hopefully this was helpful. We didn't go off on too many tangents. And if this sounds like something that you're going through, like talk to a pelvic health provider that can really get you to the right person. And make sure that if you are receiving pelvic floor therapy for this, that you have somebody that's working outside of just the pelvic floor. Because I I can think of 3 right now, people that I'm seeing that have had pelvic floor therapy prior to seeing me for these reasons and never got anywhere and just said it just continued to hurt. And now by treating the way that I know Roxy and I both treat, is having pain-free sex and for the first time ever in their life and are just beyond excited and are working additionally in other areas of their pelvic health as well. So anything else, Rox?
Yes, actually. Yes, a final thought on just the idea too that this is like a really private conversation that a lot of people don't ever want to have. And we just recognize that and acknowledge that. But to be by ourselves and isolated and let ourselves like not tell anybody about that is really kind of a scary place to be. And that's basically where so many people that come in that have been dealing with this for a long, long time just have never said anything to anybody about it. And that can be really lonely and also not encourage like health, I guess I should say. So it doesn't matter really who you tell, but if you can tell somebody and kind of feel like you have encouragement in some way, shape, or form, rather than suffer in silence, that's just our heart too in this. If we see a lot of our patients have done that for way too long. They've missed out on good quality of life, and that's really kind of sad to see. And so, just warning you, don't be by yourself. It can be kind of embarrassing in private, but everybody who has gone through this and came out on the other side, they never say, "Man, I'm glad I waited this long to do this." It's almost always like, "Man, I wish I would have done this sooner," or "I wish I would have known about this sooner." And so, that's something we want to encourage y'all with if you're feeling nervous about kind of where you're at with it.
Absolutely. Well, we're going to wrap this episode up, but stay tuned for our next episode because Roxy and I are leaving this week to go to Pelvicon 2024, which is one of the most amazing conferences for pelvic health professionals. This episode will air actually once we're back. And so then when you finally hear that episode, we will have been back for a couple of weeks and we'll give a rundown on everything that we learned and all about it and our thoughts on it. But we look forward to it every year. And so Roxy and I this week are going to be meeting up in Atlanta and staying together in the hotel room. So who knows what good stuff we're going to come up with. All right. Well, thanks for listening, and we will continue the conversation next episode. Thanks.
See ya.
Thank you so much for joining us this week on the Pelvis Project podcast. Help us continue the conversation by liking and sharing this episode with friends. And if you really want to do us a solid, leave us a review. If you'd like to follow us on social, check out the show notes for links. And remember, this week, take a deep breath and relax your pelvic floor.